Hello everyone. So let us continue with the fourth presentation in the Strabismus series. So let us today discuss something about divergent squint, that means exotropia. So what is exotropia? It is a condition where one eye deviates outward while the other eye fixates. This is very important. Now you can see here, this is exotropia and this is a normal eye. So here the one eye deviates outwards while the other eye fixates. Now, there are different clinico-etiological types of divergent squint. The first one is congenital exotropia. It is usually present at birth and this is kind of rare. Here there is a large angle deviation of the eye laterally or towards the outer side, that is the lateral canthus. Usually it is alternating and there is no amblyopia. Here there is homonymous fixation in the lateral gaze. Coming on to the primary exotropia, which is most common. It can be unilateral or alternating. The various subtypes are: number one, convergence insufficiency type, in which the exotropia is more for near; divergence excess type, in which the exotropia is more for distance; and the basic type, here the exotropia is equal for near as well as distance. What are the key features? Here it starts as intermittent exotropia at around 2 years of age. Initially the fusion is normal and in early stage there is no amblyopia. Stereopsis is usually absent, very important feature. So how it is triggered? It is triggered by bright light, fatigue, ill health, or even during daydreaming. If this is left untreated, this becomes constant exotropia and then there are chances of amblyopia. Alright. Now coming on to the secondary or a sensory exotropia. Here we have already seen like there is sensory esotropia. There were the causes in which there is vision is poor in one eye. So here it can be due to traumatic cataract, opacity, optic atrophy, anisometropic amblyopia, retinal detachment, or a macular lesion. What is consecutive exotropia? Consecutive exotropia is similarly like consecutive esotropia that we have studied in our previous class. So in that, consecutive esotropia is because of overcorrection after exotropia surgery, and consecutive exotropia it develops after overcorrection of the esotropia surgery. So spontaneous conversion of esotropia, especially with amblyopia. All right. Now coming on to the evaluation of concomitant strabismus. Okay, so let us start first with concomitant strabismus and then we will learn about incomitant strabismus. Okay, in concomitant strabismus the deviation is equal. All right, now let us start with history, which is very important. Here we have to ask systematically the age of the onset, whether the child started experiencing the deviation of the eye during infancy or in the later childhood. What was the duration? Was the duration was for the full day or for few minutes or for few seconds? All right. What was the mode of onset, whether it was sudden or gradual in onset, and what were the precipitating factors, for example if they're associated with any fever, trauma, or infection. Then we have to ask about the type of deviation. This was what we were talking about, whether the deviation is intermittent or constant, or whether it is unilateral or alternating. So we have to ask about diplopia. Why diplopia is usually absent in concomitant squint. Okay. So family history of squint we have to inquire, and abnormal head posture, whether there is abnormal head tilt or face turn. All right. Coming on to the examination. On examination, first of all we need to have a general inspection. Here the if the angle of the squint is large, then it is very obvious to the eye, so we have to note whether it is ESO or EXO, and we also have to note the head posture, okay, with head tilt or chin lift or whatever finding that we can see. Then coming on to the ocular movements, we need to check the uniocular movements and binocular movements in all the position of the gaze, and very important, the movements are normal in case of concomitant squint. Then we need to look at the pupillary reactions, which may be abnormal in a sensory squint, which might suggest it is a retinal disease or an optic nerve pathology. Otherwise, usually pupil reactions are normal. Then we have to check the media and the fundus examination to rule out cataract, corneal opacity, any retinal disease or optic atrophy. So these are the important for detecting secondary exotropias. Coming on to the fifth point, that is the vision and refraction, which is very important. We need to check the visual acuity of every patient presenting with squint to detect amblyopia, and especially cycloplegic refraction needs to be performed. Alright, so if refractive error is any, we need to correct it because this might contribute to the symptoms either ESO or EXO. Alright. Now the tests. Coming on to the cover tests, which is very important. There is direct cover test and then there is alternate cover test. In direct cover test, patient fixates on the target and we cover the normal eye as we have done here. Then we have to see the uncovered eye. So this is the uncovered eye and then we have to see. What is the interpretation? If there is movement on covering the normal eye, then this means manifest squint is present. If there is no movement, then this means apparent squint might be present. So we have to do it for both as well as for far. Coming on to the alternate cover test. In this, what is the purpose? To detect the aniphorias or latent squint and type of squint, whether it is unilateral or an alternating squint. It also helps us differentiate between concomitant versus paralytic squint. So here, what we have to do is, we cover one eye and alternately cover the other eye. Means we rotate the occluder between one eye and the other eye, and then we check the movement of the uncovered eye. Alright, so that will tell us whether the squint is present or not. So how we will detect it? In case of concomitant squint, primary deviation will be equal to the secondary deviation, and in case of a paralytic squint, secondary deviation will be more than the primary deviation. Now the question might arise in your mind, what is primary deviation and what is secondary deviation, because we have not talked about it earlier. So let us see. What is primary deviation? Primary deviation means when the normal or the non-affected eye is fixating on an object, the affected eye deviates. This is the primary deviation. In this, the normal eye is fixating. This is very important thing to learn. The second thing is the secondary deviation. In secondary deviation, the affected eye is fixating. So when the affected eye is forced to fixate by covering the normal eye deviates. So now that is the secondary deviation. In primary deviation, the normal eye is fixating, okay, and the affected eye deviates. Alright. In secondary deviation, here the affected eye is forced to fixate and the normal eye, and hence by covering the normal eye, and hence the normal eye deviates. So that is why in paralytic squints, the secondary deviation is more than the primary deviation, and in case of concomitant squint, primary deviation is equal to the secondary deviation. This is the very differentiating point between these two squints on the alternate cover test. So what are the key points? Normal ocular movements are seen in concomitant squint. We all know that. We always have to do cycloplegic refraction in children who present with squint. Very important to give appropriate refractive correction to correct these squint, because we have learnt in esotropias there are refractive accommodative esotropias, non-refractive accommodative esotropias. All right, and then cover test, which is the most important clinical test, and fundus examination is always done to rule out any sensory cause. So everybody's following up till now. All right. So now, how to measure the angle of deviation? So we are having different tests that help us measure the angle of deviation. The first one is this Hirschberg's test. It is a very rough screening method. All right, rough screening method. So how do we do this? In this, we observe the corneal light reflex. All right, so if it is a normal reflex, then it is at the center of the pupil. Okay, so in this case, if at the pupillary margin, then we can say the deviation is around 15 degrees. If it is at the limbus of one eye, then we can say it is around 45 degrees. It is simple and quick method for estimation only, not accurate method at all. It just gives us an idea how much it could be. Then coming on to the prism bar cover test, we have already learned in our previous classes. It is a gold standard test. Here we place the prism with apex towards the deviation, which I have already told you in our previous classes, and here we will perform the cover and uncover test. We increase the prism strength until there is no recovery movement. This is very important. Okay, so here what is the result? The prism diopter will be the angle in the prism power will be the angle in prism diopters. It is used to measure both heterotropias as well as heterophorias. Very important. We already done and understood this test already in our previous slides. Coming on to the Krimsky test. So it is an objective method. It is used in children and uncooperative patients. How we do it? The patient is asked to fixate on a light and we place the prism in front of the normal eye. You can see this is the normal eye. We have placed the prism in front of the normal eye and we start increasing the power of the prism until the opposite eye, you can see here the opposite eye, the reflex is centered in the squinting eye. Very important. We place the prism in front of the normal eye and we increase the power until the reflex is centered in the squinting eye. So the result is prism power is equal to the angle in the prism diopters. Coming on to the synaptophore, it is most accurate and advanced instrument to measure the objective angle as well as the subjective angle of the squint. It measures both heterophorias and tropias, and additional uses are it also helps test the fusion, stereopsis and retinal correspondence. It is highly accurate and it is multifunctional. We have already read about it. Now coming on to the comparison table, this is very important. I have summarized for you guys. There are tests to check the angle of the squint, Hirschberg test, PBCT, Krimsky and the synaptophore. Synaptophore is both objective and subjective test. Alright, and PBCT is a subjective test. Krimsky is an objective test. It is used in children and uncooperative patients. PBCT is the gold standard test. It's a very subjective test. Accuracy is very high. But synaptophore has even more higher accuracy than the PBCT gold standard. Okay. So for detailed evaluation, we might use synaptophore. Hirschberg test, it is just a screening test just to have an estimate of whether the squint is present or not and how much degrees it could be. But the exact prism diopters, the deviation in prism diopters, we need to check with PBCT. All right. So what are the goals of the treatment? Goal is to achieve the good cosmetic alignment, improve the visual acuity and maintain the binocular single vision. What are the treatment modalities with us? So very important in all cases of squint, we need to have a spectacle correction, full correction of refractive error in all cases, which improves the vision, or it can partially or completely correct the squint if it is an accommodative squint, whether it is especially refractive accommodative squint. All right. Coming on to the occlusion therapy, this is indicated in cases of amblyopia. So what are the steps? First of all, we need to correct the refractive error. Then we need to patch the normal eye and we have to force the use of the squinting eye. It is most effective up till we can say 8 to 11 years of age. Why? Because after 8 to 11 years of age, the plasticity of the nerves decrease. So here it requires a regular follow-up. Then we can have preoperative orthoptic exercises. These are done after the amblyopic treatment. Take a synaptophore exercises we have. In this we can do after the treatment of the amblyopia. Why it is done? To eliminate the suppression and improve the binocular function. Then the other thing that we can do is squint surgery, which is required in most cases. It is done only after the refractive error correction, and if any residual amblyopia is present, we need to treat it and we have to decrease the suppression by the use of orthoptic exercises and improve the binocular single vision, because otherwise after squint surgery there could be diplopia. So what are the basic principles? We have to weaken the strong muscle, that is the recession. Okay? And in recession we don't cut the muscle, we just move the insertion of the muscle backwards. All right. Or we can strengthen the weak muscle. How? By resection, by shortening the muscle. In this we cut the muscle. All right. Now amount of approximate correction for a medial rectus. For if there is 1 mm resection, there is around 1 to 1.5 degrees correction, and if there is 1 mm recession, then 2 to 2.5 degrees correction can be seen. Maximum resection of medial rectus is 8 mm that we can do, and maximum recession is 5.5 mm. All right. Now lateral rectus, 1 mm resection or recession corrects 1 to 2 degrees of squint. Maximum resection can be 10 mm and maximum recession can be 8 mm in case of lateral rectus muscle. Post of we need to have pre-operative orthoptic exercises as well as post-op orthoptic exercises, which are very important. So they improve the functional range and hence maintain the binocular single vision. Thank you so much for bearing with me during this presentation of divergent squint. I will meet you in the next class with another presentation on squint. Thank you so much.